So good morning, everyone. Thank you so much for coming. My name is DeAnna Baker Frost. I'm an assistant professor at the Medical University of South Carolina in Charleston, South Carolina, where I'm a rheumatologist, and I'm also a researcher, and I've been spending the majority of my career thus far researching scleroderma, as well as seeing scleroderma patients. So I'm very grateful to the National Scleroderma Foundation that's funded part of my research and gave me an opportunity to speak to you guys today about Scleroderma 101. So I want to give a couple of housekeeping genes. So you have the handouts with you. As I was going over them yesterday, I switched the order of some of the slides. The information is still there. The order maybe switched around a little bit. So I just wanted to give you some information about that. And I really like to have interactive discussions. So as I'm presenting, if you have any questions, you can just raise your hand during the talk, and I'm happy to entertain the questions at that time. If you prefer to wait to the end of the talk to ask questions, then that would be fine as well. So I guess we'll go ahead and get started. So for the first thing I wanted to discuss is, why do we even call scleroderma? Where did that name come from? So the name scleroderma actually means hard skin. And so it kind of describes what the early physicians saw when they diagnosed the patient with scleroderma. And so in their minds, when they saw the skin thickening, which they did not understand at that point, they just knew that it was hard. And so that's where the name came from. However, there are two different forms of scleroderma. So when you hear the word scleroderma, it doesn't necessarily differentiate between the different types of scleroderma, which is what I'll go over today. So there's the localized form of scleroderma, which some of those subtypes are morphea and linear scleroderma. But then there's also systemic scleroderma, which is also called systemic sclerosis. So we use those names interchangeably. And the two subtypes of that is limited scleroderma. Some people may have used to call it CREST syndrome, and we'll kind of talk a little bit why that used to be the name for limited scleroderma, and then diffuse scleroderma. And so we'll go into that as well. So one of the major questions that I get from my patients when they come to me, they say, where did this even come from? I don't understand how did I even get this disease? And right now in rheumatology, the way that we understand autoimmune diseases is that it's a combination of lots of different things that could have occurred over the lifetime of a person that caused the development of scleroderma. So here I put a picture of pollution. So there's definitely some chemical exposures that we can for sure say can lead to the diagnosis of scleroderma. Unfortunately, it's not exhaustive, so we can't say for sure that those are the only chemicals or environmental exposures that can lead to the diagnosis of scleroderma. There are likely unnamed environmental exposures that we've yet to define at this point to allow us to understand how scleroderma develops. Genetic factors is the other main component. So we now understand that there is something in a person's genes that may predispose them to developing scleroderma. Now, it's not 100% because there are family members that people may have that don't have any autoimmune diseases, and that's typically where you get your genes from. And there's been studies to show if you look at twins, like monozygotic or identical twins that have the same exact genes, it's not 100% that both twins will get the disease. So that tells us that this is not purely a genetic disease. So it's not purely the genes that cause the development of scleroderma. And then finally, cell stress. So we have lots of different stressors that occur in our body, and it causes different toxins and things to build up inside of our cells. And the buildup of those things all over time can lead to the development of scleroderma. So I would love to say that we figured it all out. I would love to say that we know 100% how this happens, but at this point in time, we believe it's a combination of all of these different factors that leads to the development of the disease. So I wanted to list some of those chemicals that has had a strong correlation with the development of scleroderma. So silica dust, typically coal miners or people who work in different construction type areas can be exposed to silica dust. And there have been some associations with the development of scleroderma with chronic and high exposure to silica dust. Vinyl chloride is another chemical that has been associated with the development of scleroderma, and then these other solvents as well. And again, as I mentioned before, this is not an exhaustive list. These are just the ones that we have strong data and strong relationships to show that with high exposures over a period of time, it can lead to the development of scleroderma, and I might say even some other autoimmune diseases. Okay, so when you have this combination of things coming together, then you have the manifestation of scleroderma. And so as I mentioned several times, it's a combination of environmental factors as well as genes that lead to the development. And so when we talk about the different aspects of scleroderma, there's three big things that we think come together that actually lead to what we see when we see someone with the disease process. So inflammation is a large part of scleroderma. So these little cells up here are called immune cells. They're the cells in our body that helps to fight off infections, to protect us from viruses and bacteria. But unfortunately, in lots of autoimmune diseases, those cells can then turn against our body and start attacking our body and releasing lots of proteins that are called inflammatory proteins. So that's one big aspect of scleroderma. The next aspect is vascular damage. So vascular damage is our blood vessels. So those are the vessels that feed our organs, oxygen, and all of those things. And unfortunately, the cells that line those blood vessels can also be disturbed, can also lead to be dysfunctional. It can also lead to some changes that we see in patients with scleroderma. And then finally, fibrosis is the other piece. And we all know about fibrosis. That's what leads to the skin tightening of the hands, the scarring that occurs in the lungs and other organs. So these are the three big components or the three big aspects of scleroderma. Now I'm kind of going to go a little bit more into different subsets because remember, scleroderma is just really the generic term. And so now we want to get a little bit more specific as to what these terms actually mean. So when we break down scleroderma, we can look at it in the localized form of scleroderma. And two big categories in localized scleroderma is morphia and linear scleroderma. So I have some pictures that are coming up. I tried not to put any disturbing photos in there, so I just wanted to give you a little warning about that. So localized scleroderma is typically classified as having a plaque that occurs on the skin. Now, sometimes it can be circumcised or a round plaque as depicted in this cartoon, and it can occur in different areas of the body. So it's not necessarily in one location and where it occurs. When the plaque is inflamed, you tend to have like a violaceous or a purple border around the plaque, which you can see quite often in patients who have active morphia lesions. Sometimes instead of having the individual plaques that occur, you can have more of those plaques kind of come together or coalesce together, and you have generalized morphia. So you have a more widespread involvement of the plaques that occur instead of like the individual plaques with circumcised morphia. And then finally, you can have linear morphia. So linear morphia is where you can have an entire like arm or limb that can be involved and it's not necessarily in the plaque form. So I'll show you now some pictures. So this is a picture of a person that has localized or circumcised morphia. So you can see the purple border that's around the plaques, and you can see that it's present really on one leg as opposed to the other leg. So that's one of the hallmarks, is not necessarily present on both limbs at the same time. This is another example of someone who has morphia, and we believe that this is an active lesion because the border is more purplish in color. If it starts to turn more brownish in color, we believe the inflammation is starting to resolve at that point. And then finally, this is another person with a darker skin complexion that has circumcised morphia as well. This is someone that has more generalized morphea. So now you can see the difference between the circumcised morphea and the generalized morphea, because you can see it's much more widespread over the legs, much more widespread over the arms and on the trunk area. And sometimes it can involve some of the deeper skin compared to circumcised morphea, which is more so on the skin surface. And then finally, you can have linear morphea. As I said, you can see kind of one limb that's more so affected than the other limb. You can also see that this is more kind of linear in nature. So it's almost a line right across the abdomen. And I put this picture here because it can sometimes follow what we call in medicine a dermatomal pattern. So in our bodies, we have lots of different nerves that come off of our spinal cord. And all of those different nerves can innervate different skin areas. And so when we have these dermatomal patterns here, morphea can actually, or linear scleroderma can actually follow some of those dermatomal patterns. So we can then go back and say, oh, it's following the C1 pattern or the D1 pattern or and so forth. There is another specialized type of morphea called coup de sabre. This is where someone will actually have a linear morphea region on their scalp. And so it's called this because it means with a stroke of a sword. And so again, a physician who initially described this entity thought it looked as if someone was hit with a sword and on the scalp area. So rarely it extends deeper, but in some instances, some patients can have it extend much far deeper into the scalp that it can actually affect the skull area. So those are all the different aspects of localized scleroderma. So now we're going to go into systemic scleroderma or systemic sclerosis, and that's divided into two subsets called limited scleroderma and diffuse scleroderma. And one of the big differences between localized scleroderma and systemic scleroderma is the fact that systemic scleroderma tends to have internal organ involvement. So you can have more than just the skin involved. You can have some of the organs involved on the inside. Typically, someone who's been diagnosed with systemic scleroderma almost always have certain areas of the body involved, such as the hands, the blood vessels, and also the gastrointestinal can also be involved as well. And so we'll kind of talk about that a little bit more. And so this cartoon just kind of depicts that the chronic inflammation and the fibrosis can affect the skin, the blood vessels, and the internal organs. So as we're kind of differentiating systemic sclerosis in our two categories, the question is, how do we come up with the designation of limited scleroderma versus diffuse scleroderma? And it really is dependent upon how much of the skin is involved, and that's how we come up with the diagnosis. So this is how we think of someone with limited scleroderma. They could have skin tightening that's present from the fingertips basically up to the elbows, from the feet basically up to the knees, and the face can be involved. And that's where the skin disease is limited to. Converse to that, someone who has diffuse scleroderma will have involvement of basically the entire body, but specifically the chest and the abdomen areas. And so if we start to see someone that has skin disease that's now involving the middle part of their body, the trunk, as well as the thighs, we now start to think that that person likely has diffuse scleroderma. And the differentiation is actually important because it can give us a clue as to things that could happen as time goes on with the disease. And we'll talk about that a little bit more. So historically, limited scleroderma used to be called Crest syndrome. And so you may have heard that from some of your physicians or things like that. And Crest syndrome stands for calcinosis. And calcinosis is the deposition of calcium that can occur under the skin and sometimes in certain joints. Raynaud's phenomenon, which we'll talk about a little bit more, which is basically the spasming of blood vessels, typically in the fingers and the toes and the peripheral areas, causing the color changes of the fingers. or esophageal dysmotility, which is the heartburn and the difficulty with swallowing that can occur with scleroderma. Sclerodactyly, which is the skin tightening specifically of the fingers, not necessarily the other parts of the body, as well as telangiectasias, which is basically little dilated blood vessels that can occur anywhere, but mainly on the face. It can occur inside of the mouth. It can occur on the palms of the hands. And so when someone saw this constellation of symptoms, they came up with the name CREST syndrome. Initially, it was associated with people that had limited scleroderma, but these symptoms can occur with someone who also has diffuse scleroderma as well. So it's not necessarily specific to that entity. So that's why we don't necessarily use this to describe only limited scleroderma patients, but it can be helpful as a reminder of the different symptoms that anyone with scleroderma can have. Now, someone that has diffuse scleroderma tends to have more truncal involvement, as we said. So you can see that you have more involvement of the chest compared to someone who has limited scleroderma. And I specifically put this picture here of someone with a darker skin complexion because sometimes it can present as color changes of the skin and not necessarily as hardening or thickening of the skin. So sometimes this can lead to a misdiagnosis for some patients if the physician is not aware that this can also be a manifestation of diffuse scleroderma. And as I mentioned before, some of the other characteristics or symptoms that can happen in both a person with limited and diffuse scleroderma is gastrointestinal involvement. And so here we have from your mouth all the way down to your stomach, and you can see that you can have heartburn issues, and we'll talk a little bit more about that. But this is a symptom that can occur in both patients with limited disease as well as diffuse disease. And as we mentioned with the hand symptoms, I just wanted to give a picture of what sclerodactyly looks like. Sclerodactyly can occur in both patients with limited scleroderma as well as diffuse scleroderma. But sometimes patients that have limited scleroderma doesn't have as much sclerodactyly, so they don't necessarily have as much skin tightening specifically of the fingers, but the fingers just look what we describe as puffy. They look a little bit larger than what you would necessarily anticipate the fingers looking like. So this is something that we typically see in patients with limited scleroderma, but sclerodactyly can happen in both patients with diffuse scleroderma as well as limited scleroderma. So with Raynaud's phenomenon, as I mentioned before, it's where we have the spasming of the blood vessels, specifically leading to the periphery, the digital periphery, as well as the toes, which leads to color changes that can occur. So oftentimes your physician may say, have you noticed color changes of your fingers? Do they turn blue, white, and red? And these different colors kind of depicts what's happening inside of the body. So when we have the white color changes that's occurring up here is where we have the initial loss of blood flow, the initial spasming of the blood vessels, so blood flow is not reaching to that point. Then they start turning blue as a result of that lack of blood flow. So that's when you start having the blue and dusky appearance that can occur with the fingers and toes. And then finally, once the spasming has resolved and you start to reinitiate blood flow is where typically the red color can come from. Not all patients will necessarily have all three stages of the color changes, but typically with Raynaud's phenomenon, we would expect at least 2 of the 3 color changes to occur. Now, you may have seen this in some of your rheumatology offices. We use either this type of dermatoscope or a full-fledged microscope to actually look at the blood vessels in the capillaries at the bases of the nails. And what we're looking for is trying to see if we can see damage to those blood vessels. So in a person that does not have scleroderma, we can see that they have long, healthy-looking capillaries that's occurring from the nail bed and going forward. But someone with scleroderma, sometimes we see a loss of those blood vessels. They don't occur. Sometimes we see that they're damaged and they're big and puffy. Sometimes you can see that they're just not connected with the area below. And so all of those things give us a clue that Raynaud's phenomenon is likely occurring, and it's probably related as a result of scleroderma. So I'll quickly also talk about the different organs that can also be affected with the disease. So you can have GI involvement, but it's important to remember our GI tract starts from our stomach and goes all the way down to our bottom. And so from the stomach to the bottom can all be involved as a result of scleroderma. So we know about the acid reflux and sometimes difficulty swallowing that can occur because of scleroderma. And it's caused by fibrosis that can occur in the GI tract. So you don't have the normal movement of the esophagus to move the food from the stomach all the way down. The same thing can occur with the lower GI tract, which involves the small and large intestines as well as the anus. This is where you can have a lot of sometimes going between constipation and diarrhea can happen quite often. Sometimes a lot of bloating can occur as a result of that, and as a result, decreased food intake and weight loss. With lung disease, this is one of the things that I know we talk about a lot, and a lot of the medications we have is targeted towards this. This is a CAT scan of someone's lung. The black areas here is a normal lung filled with air. Air should be black. So this is what we expect to see someone that doesn't have any scarring of their lung. And this, unfortunately, is someone that may have lung disease as a result of scleroderma. So you can see that the nice black area is now filled with a lot of white linear structures, sometimes puffy, fluffy looking structures, and all of those are signs of fibrosis or inflammation that's occurring. Some symptoms that patients may have if they're developing lung disease is shortness of breath. Sometimes they may develop a dry cough. Sometimes they can have unexplained fatigue, and sometimes they just have decreased exercise tolerance, meaning that they cannot do the things that they would normally do over a period of time. This is a very complicated picture, but the point of it is that you can also have narrowing of the blood vessels that occur in the lungs as well. So we talked about the Raynaud's phenomenon where you have spasming there, but this is someone who has pulmonary hypertension. And so instead of all the blood vessels being nice and open from the heart leading to the lungs and coming back, you can see that those blood vessels are now narrowed, unfortunately. And sometimes you can have a lot of the same symptoms if you're developing pulmonary hypertension that you can have when you're developing interstitial lung disease. You can have shortness of breath, you can have fatigue, you can have decreased exercise tolerance, and sometimes you can have swelling in the legs that can occur as well. And then finally, one of the things that we consider a medical emergency is the kidneys can be involved in some patients with scleroderma. And this is called scleroderma renal crisis. And what happens with this is that you can have a high, unhealthy level of blood pressure that can occur in a very quick period of time. You can have certain blood counts that can change very quickly that can lead to kidney disease. And we're kind of seeing a trend here. So we see like these open blood vessels that would typically occur in the kidneys. But unfortunately, if someone who's having scleroderma renal crisis, those blood vessels are now constricting. They're becoming smaller, which can lead to the hypertension that someone can detect. And so we'll talk a little bit more about that later, how we can diagnose this very quickly. But I just wanted to you guys to be aware that this entity occurs. And then finally, one of the other things that can happen is you can have muscle inflammation that's resulting from scleroderma. And so the words aren't necessarily as important in here, but I just wanted to show you the pictures of the different muscle groups that can be affected. So there are only certain muscle groups that are affected if you do have muscle inflammation related to scleroderma. So you see your shoulders, you see the hips, those muscles can be inflamed as a result. Some of the symptoms that people can have is they have weakness or heaviness with combing their hair in the morning, brushing their hair, rising from a seated position. You may develop a rash as a result for some people. And the esophagus is also lined with muscles. And so that can also be involved. So sometimes the difficulty swallowing, which we attributed to heartburn, could actually be related to muscle disease as well. So that's something that can also occur. So I talked about all of the different aspects of things that can, all the different groups are affected. So when you see your rheumatologist, our thought is to try to ascertain if any of these things are happening. And we try to do that at least at every single visit. So one of the things that you often find is that your rheumatologist will pinch your skin a lot. So I tell my patients all the time, I go around pinching skin all the time. And this is the way that we can determine the amount of skin thickening that's occurring, especially over time, if it's getting better or if it's getting worse. And this is a scoring system that was created by Dr. Rodnan called the Modified Rodnan Skin Score. And it's typically performed by a trained rheumatologist. And you can see that this rheumatologist is pinching skin, and based on the amount of wrinkling that occurs with the skin can help you to determine how much skin thickening is there. And this picture did a really good job of looking at a normal person or a person who doesn't have scleroderma and a person who has increasing skin thickness, and you can see the decreasing amount of wrinkling that occurs as a result. And so what we do is we pinch 17 different areas of the body, and we give a score of 0, 1, 2, and 3, and we add up all of those numbers and we record it. And we typically do it more often than not at every visit to see if any of the interventions that's been done has improved any of the skin thickening. We talked about scleroderma renal crisis and how it is urgent that we diagnose it. So this is what your blood pressure cuff looks like in your doctor's office. And they'll always measure your blood pressure at every single visit. However, we also encourage you to get a blood pressure cuff at home. It doesn't have to be anything fancy like the one at the doctor's office. Any blood pressure cuff that you get in one of your local pharmacies can be sufficient. If you're concerned that it's not adequate enough, you can always speak to your doctors about it. But we encourage you to monitor your blood pressure at home at least on a daily basis, typically first thing in the morning with your feet flat on the floor while you're not speaking, so that we can get accurate readings. If those numbers are elevated consistently over time, we urge you to speak to your rheumatologist as soon as possible because medications may need to be started in an emergent fashion. Sometimes we do blood work at the doctor's office, and it depends upon what we're looking for. If there are medications that require blood monitoring, so we may have to get certain blood tests that occur on a frequent basis. Sometimes we need to check for different autoantibodies that can help us further define what's happening with the disease, or if new things are coming up, or if things are getting better. So this may not necessarily occur at every visit, but more often than not, then we may have to do some blood work. Some of the other autoantibody testings that we can get are typically because these are proteins that are made against our own body cells. You probably heard of the ANA test. That's typically one of the early screening tests that we do for autoimmune diseases, including scleroderma. But these are some of the other specific autoantibody testing. And I believe there are some talks later today that'll go into a little bit more detail about that. If we're talking about lung involvement, especially with interstitial lung disease, one of the big ways we screen for that is doing pulmonary function tests or breathing tests. This measures your lung capacity, and most of my patients tell me how difficult this test is because we want you to take in as much air as possible and then breathe out as much air as possible, even the itty bitty little air spaces that's left over. It's done in this chamber here with the help of one of our respiratory therapy technicians, and they give lots of different numbers and percentages, and we look over time at any changes in the percentages. So changes in the percentages as well as any new symptoms that you're having helps us to determine if there could be the development of interstitial lung disease. The 6 minute, oh yes.
So how often would you get that? Because I think I had it 2.5 years ago, but no one's ever given me any results or said come back.
That's a great
How
question.
often do you get that?
That's a great question. So the question was, how often should we do these breathing tests? And I think I might have it here. So at least every 6 to 12 months or so, but it really is patient dependent. So your rheumatologist will gauge for you kind of what your risk factors are developing interstitial lung disease. Like if you currently have it and are on treatment, if you were on treatment and you got better from lots of different modalities. So on average, we do it every 6 to 12 months, but it's also very patient dependent. So if it's a concern, I would ask you to speak to your rheumatologist and see if that's a test that needs to be done. Yes, ma'am. Same thing for the 6-minute walk test. So this test helps us to define if someone is having decreased oxygen saturation while they're active. So they have you kind of hurry and scurry down the hall as quickly as possible over a 6-minute period of time, and they measure your blood pressure and they measure how much oxygen you're taking in. Typically, they have an oxygen monitor. It should be across the forehead because of the Raynaud's phenomenon. It can make it very difficult to measure oxygen levels on your fingers, but they do it so that they're able to determine if there is any decrease in oxygen, which may mean that someone needs to have supplemental oxygen as a result. And again, that's typically done on every 6 to 12 month period of time, but again, it's also very patient dependent. Sometimes we also may need to do a CAT scan of the lungs, depending upon if symptoms are worsening, depending upon seeing if different treatment is occurring or treatments are improving things. A CAT scan may also need to be warranted. For pulmonary arterial hypertension, we tend to do screening tests with echocardiograms. This estimates the heart function, and it can also estimate the pressures of the heart. So if you think back to the picture where you had the narrowing of the blood vessels that's leading into the lungs, you can imagine the pressure buildup that happens because those blood vessels are narrowed. We can estimate those pressures with an echocardiogram. It's not exact and it's not perfect, but it is the screening test that we currently use. Again, that's typically done every 6 to 12 months. Again, it's also very patient dependent. If we do see changes, sometimes we have to do more invasive testing like a right heart catheterization to confirm that there are changes in the pressures that was detected on the echocardiogram.
I'm sorry.
Yes, no.
Which doctor does that? Your pulmonologist, your rheumatologist?
That's a great question. So the question is, what doctor performs this test? It's either the pulmonologist or the cardiologist, more often than not. I can almost guarantee it's not the rheumatologist that does the echocardiograms, but it'll be one of those two. And you may not necessarily need to have an appointment with the pulmonologist or cardiologist. Sometimes the rheumatologist can just order the test to be done, and then it's done from there. But that's also a great question. Any other questions? Okay. So I'm just going to touch very, very briefly on treatments. Again, this is not nearly exhaustive of the number of treatments that are out there, but I just wanted to give you a flavor and just kind of introduce you to some of the words you may have heard at your doctor's appointments. So again, not a complete list, but typically the naming mechanism is I have the generic name here, the brand name in the parentheses. So you may have heard either one or both of the terms for the medication. So some of the immunosuppressive medications that are used is mycophenolate. It can also be known as Cellcept. Sometimes it's known as Myfortic as well. Methotrexate is another immunosuppressive that some people may have heard of. The antifibrotic medication that's FDA approved currently is nintedanib. Ofev is the other name that you may have heard of. There is a whole list of pulmonary arterial hypertensive medications. So this is just one of them. Sildenafil or Viagra Revatio is the other name that you may have heard of as well. For gastrointestinal medications, we tend to use protein pump inhibitors to help to treat the heartburn. I only gave Nexium as an example, but there's Prilosec, there's omeprazole, there's so many other ones that are out there, but they're all in that same class of medications. And then for Raynaud's phenomenon, we typically use initially calcium channel blockers. Amlodipine is one that you may have heard of, or Norvasc is the other generic name or the other brand name for it. Again, this is not nearly an exhaustive list, but some of you may have already heard maybe on some of these medications. Yes, ma'am.
I have a question.
Yes.
Some of the pulmonary hypertension medications actually help right now.
That's
like the,
excellent.
The Viagra.
Yes, yes, yes. So, yes, thank you for that. She brought up an excellent point that some of the medications that are currently approved for pulmonary hypertension can also help with Raynaud's phenomenon. So I listed this under pulmonary hypertension, but sometimes I use this medication to help people with Raynaud's phenomenon. And if someone unfortunately is diagnosed with pulmonary hypertension, they may not need to be on medicines for their Raynaud's phenomenon because the medications themselves can take care of the vasospasming that's occurring in the heart as well as in the fingers. So that's an excellent point. Very good. So what to expect over time? When we go back to localized scleroderma, it typically resolves. So you tend to see resolution of the skin thickening that can occur in the different types of plaques. Again, very patient dependent. However, some patients don't achieve the spontaneous resolution, and they may need to be placed on different types of immunosuppressive medications. And rarely do we see organ involvement with localized scleroderma. So some people with localized scleroderma may not necessarily undergo the screening test that I mentioned before because they rarely get organ involvement. I say rarely. I've been doing this long enough to know that anything could happen. So rarely just means just that rarely. It doesn't mean that it would never happen.
I have another.
Yes.
We have I'm a support leader,
Mm-hmm.
and we have a person in our group that has the, I guess, the linear, where one side of the body is different than the other side.
Yes, ma'am.
And one thing that has really helped her, which she hadn't gotten early on, is physical therapy.
Absolutely.
To help get beside.
Yes.
I think you should include
Yes.
that.
Absolutely, 100%. Again, bringing up another excellent point in the benefits of physical therapy. So I cannot say enough how important physical therapy, occupational therapy can be with someone who has either localized or systemic scleroderma, because it can help with your exercise tolerance, it can help with your breathing function, and if someone does have any deformities that is related to localized scleroderma, it can help to strengthen the remaining muscles that's there. So again, excellent point. Really, really important to remember. Physical therapy and occupational therapy are big, big, big helpers. Medications is typically not enough. Physical therapy and occupational therapy is also very, very key. Thank you for that. Yes.
Being in the tropical sun, does sun have anything to do with?
That's a great question. So the question was, does sun exposure help or hurt related to the disease process? So for some people that have actually localized scleroderma, in some instances, UV light can actually be helpful for them. So some dermatologists, maybe even some rheumatologists, do prescribe kind of not, laying out in the sun at the beach all day long, but kind of monitored closely sun exposure to help with that. So that can be helpful. Conversely, for people who may have rashes that's related to systemic scleroderma, sun exposure can be harmful. So I would say if that's something that you're considering, talk it closer with your rheumatologist that knows you closely, knows all of your manifestations, and then they can kind of help to guide you whether sun exposure could be helpful or harmful to you. But it can be helpful and harmful in different instances. You're welcome. Okay, so one of the things that we look at is how long someone has had scleroderma. That's not necessarily when they were diagnosed with the disease. And so unfortunately, we know diagnosis can lag behind when the symptoms actually first start, depending upon if you are seeing a provider that understands and is familiar with scleroderma. So from the time when symptoms first start, lots of researchers have been able to plot out exactly what they think could happen. Again, could happen. This is also not 100%. It is very person dependent. But on average, when we're talking about skin thickness, when we're talking with someone who has the diffuse form of scleroderma, very early on, they can see a rapid rise in skin thickening and also issues with their internal organs. And then after the 5-year mark is where we tend to look at, you can start to see some resolution, some improvement in some of the skin thickening that can occur. For someone who has limited scleroderma, in the beginning, you already don't have as much skin thickening to occur, but over time, you can see some other manifestations that start to develop a little bit more rapidly the longer that treatment occurs. So the time in which someone has the disease helps us to determine what we can likely expect. So again, for someone with limited scleroderma, over time, they are at a higher risk of developing esophageal disease, pulmonary hypertension, some issues with malabsorption or absorbing things into the stomach. So that means that because those risks are higher, we tend to look very, very closely and do those monitoring tests like the echocardiogram very, very closely to keep an eye on things as time goes on. When we're talking with someone that has diffuse scleroderma, very much early in the disease course is when we see a lot of activity happening. We see the skin disease thickening. You're at an increased risk of getting the muscle inflammation and the lung disease, high risk of getting sclerorenal crisis. But then over time, those risks kind of wane. So very early in the disease course of someone with diffuse scleroderma, we want to be very, very cognizant of monitoring and looking for any of these types of involvement. And I will say that even though the risk may go down over time, if there was any damage that occurred, it doesn't mean that damage goes away, unfortunately. So oftentimes we're left with the result of the early activity which occurs. So the lung disease may not be active, but the issues that occurred because of the lung disease can still be present. Yes, ma'am.
So look back when you get a patient, like sometimes it's 2 or 3 years or 5 years before they're diagnosed, or is this a timeline after they start medication that they improve?
Excellent question. So the question is this pre or post treatment, if I could say that. And so this is if we look at the disease course, not necessarily involving treatment. This is looking at what could potentially happen if someone has the diffuse form of the disease versus the limited form of the disease. Now, we hope that if we detect lung disease here, we're able to halt it and we don't have kind of continued progression from that point of view. This helps the physicians to determine, okay, this could happen. These are the things that we need to look out for. These are the screening tests that we need to enact so that we can monitor for these things and hopefully catch them soon so that we can intervene as possible. So yes, sir.
On the limited, on the previous slide, I think you said 5 years.
Mm-hmm.
Start to see that. Is that time horizon the same on this for diffuse?
So time is still the same, yes, sir. So it'd still be the 5-year span. And again, that is a rough estimate, that's still a rough estimate, but that's where we kind of start thinking, okay, skin disease can start resolving. We're concerned that other things may become more active or more in play over time. But I tell my patients, long story short, I monitor everything all the time. I don't have a clock to say, oh, it's 5 years. Now let's start looking for this. From day one, we start initiating and screening for any of the manifestations that can occur as a result of scleroderma, whether I just diagnosed you yesterday or you've been with me for 10 years. So here's the review that I have. Again, localized scleroderma, typically isolated to the skin. It can be in patch form or linear form. If it's acute sabra, it can involve the scalp area. It typically doesn't affect internal organs, and it can improve with or without medications. For someone who has systemic scleroderma, it typically involves the hands, as well as, and I can add a couple things to that, as well as the GI tract, as well as the blood vessels. There are 2 big types we define as limited disease as well as diffuse disease. It can involve internal organs, but it's very dependent upon the type of scleroderma that you have, how long you've had the disease, if interventions were done at an early time point, and it harps on the importance of regular screenings for those things. Medications may be needed, but depending, of course, upon your current disease manifestations, you may not necessarily be on medications. With that, you've already been asking questions, but I'm happy to take any further questions. Yes?
When you at the beginning, you talked about silica dust
Mm-hmm.
and how it's in mining and construction. What is it in construction where you would have silica dust?
That's a great question. I'm not a construction guru, but I think it really is dependent upon the construction site itself. What area are you doing construction in? What's the composition of the dirt and, the concrete and the things?
And so it's more the earth versus the product that they're bringing in, like lumber versus drywall and.
It depends. My understanding is it depends on the composition of whatever you're doing construction. So it could be that there may be some components in some of the things that are being built, as well as things in the earth that could be playing a role into that.
Like
Yes.
dust, like dust.
Mm-hmm. Mm-hmm. So it's not necessarily just the earth. It could also be components of the things that are being built. Yes.
A lot of the countertops, natural and synthetic, are silica based.
Say that one more time.
A lot of the countertops
Countertops.
Yes.
Countertops.
that
Yeah.
are natural as well as synthetic
Right.
are at base. They're
Right.
silica chemistry.
Yes.
So
Yes.
I would think that cutting that
Yeah.
would probably be a dangerous
Exactly.
occupation if you didn't wear a mask.
And oftentimes, if someone does develop any type of autoimmune disease, especially lung disease, they do a very thorough occupational history to ask if you have had any type of these exposures. I talk to my pulmonary colleagues and they have a long questionnaire of things that's often administered of different exposures, like, if you were a cutter for countertops and those types of things to kind of help to define. But again, it's really hard because we're exposed to so many things in our environment, and unless we all live together in one little bubble and we're all exposed to the same environment, it's very hard sometimes to tease out those environmental associations. Yes, sir.
Obviously, in construction, one of the more common is in concrete drilling.
Mm-hmm.
Powder form of concrete being mixed. And so on construction sites, they'll really harp on dust masks.
Mm-hmm. Mm-hmm. Mm-hmm.
That's one of the most common.
Mm-hmm.
In dealing with concrete, whether it's drilling or the powder form, when you're mixing concrete, those dust particles that you inhale those. And then
Absolutely. Absolutely. Yes, sir.
Thank you, Dr. Frost.
Yes.
Great talk.
Thank you. Thank you.
It seems like in other autoimmune diseases, there's drugs that actually alter the course of the disease. In scleroderma, there doesn't seem to be much change, just symptomatically.
Yeah.
So why is that? Number one, is there anything that you're excited about coming that may do that?
That's an excellent question. I think that is the holy grail of, of what we do, especially me as a researcher. So unfortunately, as of late, we had been limited symptom management for scleroderma, such as like with proton pump inhibitors for esophageal disease. However, we do have nintedanib on the market now, which is the first antifibrotic, which means it is a medication that can slow the progression of fibrosis, which can be disease modifying. The biggest issue is side effects that can occur with that, unfortunately, as well as tocilizumab, which is an anti-inflammatory medication that specifically targets IL-6, which is one of the main inflammatory molecules in scleroderma. So we're making slow progress, but we're making some progress towards that. My training is in immunology, and so I am very fascinated about the immune system and how it can cause inflammation. And so I think looking closer at how the immune system plays a role into this, I know everyone has heard of CAR T cells. I know it's the hottest and the biggest thing right now. But so I am intrigued about how we can maybe manipulate the immune system to see how, if we can prevent inflammation from occurring, then likely we can prevent fibrosis from occurring as well. And so So I'm interested more in that, in those studies and seeing how that can turn out. Yes. Okay, I'll go to the back row back there. I have two hands in the back row.
They're
Oh.
building new columbarium, and I think 3 days into it, there was a big boundary so that those of us, the parishioners going into the church, were not close to that. And they said specifically, we found this and this,
Mm.
that's dangerous, and so we were to go through another area. So I wonder if they're looking for that, because that was within 3 days that they closed it out for the parishioners.
I think, unfortunately, we used to use a lot of materials and things that we didn't know. I always go back to cigarette smoking and how, you used to have physicians smoking in the office with their patients, back in, and now we know that that's probably not a good thing to do. So I think over time, we're now learning, unfortunately, that, the materials that we used to use and we thought were safe are unfortunately finding out that they're not as safe as we thought they were.
And that is a mission church, so it's been, hundreds of years. So.
Yeah, exactly. Yes, ma'am. The lady in the back, yes.
So do you see any people groups or occupational groups that are more commonly diagnosed than others? Like, are there any patterns there?
So we do unfortunately see, not necessarily, so we do see that we have people who self-identify as Caucasians can be more diagnosed with the disease, but then when we talk about the severity of the disease, we see more minoritized populations that have more severe disease. And so there's lots and lots and lots of research and studies looking into why we see that dichotomy between diagnosis and disease severity. So that's an excellent question. Yes.
Is there a prevalence or correlation with gastroparesis?
That's a great question. So I'm sorry. So the question is there a correlation between scleroderma and gastroparesis? So gastroparesis is where you also have almost paralyzation of your stomach. So part of our gastrointestinal system is the movement. So we need those muscles to move along and squeeze to help food move along. I have patients that unfortunately get gastroparesis as a result of having scleroderma.
Because I was diagnosed with gastroparesis in 2020. I didn't know if there was a connection there, or if it's just happenstance.
There definitely is likely a relationship because of the fibrosis that occurs. If those muscles get fibrosed over, then they're just not going to squeeze as much as they should, unfortunately. So unfortunately, that's also the tough part. I mean, I have patients that see some gastroenterologists and they use stimulators, like external stimulators to help with different aspects of gastroparesis, different aspects of issues with other motility issues lower in the GI tract. So I have seen that happen. But as far as a cure, unfortunately, I haven't seen that. Yes, ma'am. Yes.
What about something like brocalamine to improve the motility of?
That's a great question. So there are medications that can help with gut motility, like procainamide, erythromycin. So there are some medications that has been used for that can help. Unfortunately, they're not curative, but they can be helpful for some people to kind of get that motility going, always weighing the possible side effects of the medications. But those medications have definitely been used. I personally have used them in my patients. Yes.
Okay, so there's two things that my rheumatologist can't answer.
Okay.
I've asked him about red light therapy.
Okay.
Because red light therapy increases collagen.
Mm-hmm.
And we hear this, our bodies have too much collagen.
Mm-hmm.
So in that same category, I used to take, collagen all the time. I've been doing it for years, and then I always stop because, so does the internal collagen that I take or the outside red light therapy, does that affect the collagen should I stay off both of those? That's my question.
I see you.
They
So
don't know.
yeah. So I definitely have lots of patients that ask about that, about either fillers or taking external collagen and things like that. we don't necessarily have a lot of data to show that consumption of collagen, consumption of collagen will kind of worsen scleroderma. So we do have some dermatologists that will use fillers for some people, even people who have scleroderma, to kind of help to fill out skin areas. So that has been used successfully for some people that did not necessarily worsen their disease. But, anytime we're talking about like taking anything internally or using any type of therapy, I always tell my patients to let's talk about it together, because sometimes there's unknown side effects that can occur that can interact with other medications and things like that. So I'm always hesitant with taking supplements just because we're not 100% sure all of the ingredients that are included in those things and how they could interact with some other medications or other things that you may be taking.
Red light therapy, my doctor doesn't know about either of them.
Right? So I have seen some reports on red light therapy, but again, because the reporting is so small and the data is so sparse, it's very difficult to make kind of definitive conclusions about it.
I'm just wondering if I should stay away from it or get it.
So if it's something that a lot of people don't know about, I tend to stay away from it because I just don't know what untoward effects could possibly happen as a result.
We really don't know yet. Okay.
Yes, ma'am. I saw another hand. Yes.
Related to that, I talked to a dermatologist who had recommended that, but they also said that in Minneapolis, I would have to go like 2 or 3 times a week for 10, maybe 15 minutes at a time. So that's like an hour drive there and back. So they said, or you could get an at-home machine, but then you're looking at $5,000 to $7,000. And they said the major side effect that they've seen depends on 1 of 2 types of the UV light, that with the older version that they saw more increased skin cancers versus the newer one, and they don't have as much data on that, so they're not as sure. And I went, okay, I'm not going to be a part of that.
Yeah. And I have it like 1 minute from my house, and for $99 a month, I can do anything I want.
And I'm not sure.
Which
about
I'm
that.
doing. I'm doing PEMF.
Yeah.
I don't know if you've ever heard
Yeah,
of that.
I've not heard of that, unfortunately. Sorry.
I have one last question.
Yes, ma'am.
Do we need to stay on CellCept or whatever for life?
That's
or can we ever go off?
That is also an excellent question as well. And I get that question quite often. The question is, can you ever stop therapy? And the verdict is out on that. And I tell people because for so long in rheumatology, we actually did not have treatment interventions for patients. We didn't have anything to give them. And so now we're at a point where we actually have therapies. And so now we do have that question, who needs to be treated for life? Who can stop medications? And that answer is we honestly don't know. We do believe that there is a subset of people that likely will be fine if they stop therapies. We don't exactly know who those people will be. I always say have a conversation with your rheumatologist about kind of your disease course, how things have been going, how long you've been on treatment, any side effects that are occurring because of the treatment, and then, make a joint decision about, if you think that possibly going off of the medications would not be harmful. And then I tell my patients, we have to see what happens after that. I can't guarantee that the disease won't necessarily return.
The side effects seem to be the exact symptoms of the disease. So it's
Yeah.
it's an anomaly.
Yeah,
like,
it's
who
the
knows?
tough
Is it
part.
medication or is
Right,
it
it's the tough
scleroderma?
part. Yeah, so that's why I tell my patients, if you don't know, just call me and we'll talk about it together. So that way it's not a guessing game for you and you're trying to figure it out. And whatever information that we have out there, we can, apprise you of it. But at this point, it has to be a joint decision with your provider, your family, and then making a decision to see what happens, and then just monitoring very, very closely if that it's a decision that's made. I could think 2 more questions. Okay, actually 1 more question. I think I'll do this lady up here if that's okay.
So the proton pump inhibitors, the meprozols and your Nexium and everything, all of that side effects, everything I read is kidney issues. And then we're dealing with kidney issues, you're concerned about a renal crisis. That concerns me. I didn't start on it because I was like, why would I take something that could cause me to actually renal crisis?
Yeah. So the proton pump inhibitors, renal crisis specifically, that hasn't been associated. Now, prednisone, and I should probably say that as well, high doses of prednisone has been shown to precipitate renal crisis. So you should never take prednisone higher than 15 milligrams. Ever, because that can precipitate a renal crisis. Protein pump inhibitors definitely have their own issues and they can cause other issues. I've heard osteoporosis, maybe kidney disease as well. Again, that has to be a joint decision because untreated heartburn can also lead to Barrett's esophagus and other issues as well. So it's tough when we have, side effects related to medications, but we have to weigh the risks of the medications versus the benefits and kind of make a joint decision. Thank you, everyone. Thank you.